I invite Dr. Swetha. She's working as a glaucoma consultant in Jyoti's Eye Care, Kannur. She will be talking on when medicines fail, identifying treatment non-responders. Over to you, Swetha.
Thank you, Dr. Soumya, for giving me this opportunity. And thank you, Dr. Manju, for that introduction. So my topic for today is when drops don't drop the IOP. This is something very practical that we usually see in our day-to-day practice. Have you ever wondered why some patients just don't respond at all? The IOP is unchanged or it's increasing and something isn't adding up. So first, to know we need to know where each drop worked to know why it may not work. So who is a non-responder? Any patient who has a difference of less than 15 to 20% of IOP drop between pre-treatment and post-treatment is considered to be a non-responder. So we have to find why the IOP didn't drop. So this is a case scenario of a 64-year-old male who had a moderate POAG and his baseline IOP was 26 millimeters of mercury with a CCT of 545. He was started on a prostaglandin analog. And 3 weeks follow-up, his IOP has dropped to 24 and 23, which is just 7 to 8%. We expect at least 20% drop in 3 weeks follow-up. The patient was confident about the usage and we had asked him to demonstrate in the clinic and he had a good technique and there was no steroid or ocular surface issue. So this is the first case scenario. And second case scenario is a 72-year-old male who had an early stage of POAG with CCT of 560 and similar IOP drop. And patient says he used the drops properly, but in the clinic, poor technique was observed. So these are the two common scenarios which we see in non-responders. So non-responders can be true non-responders and it can be apparent non-responders. What do they mean? So generally we have some issues in the pharmacological of the drug. Drug can have drug resistance, tachyphylaxis, or it can have ocular barriers, poor penetration, especially when we have the carbonic anhydrase inhibitor. They cannot penetrate through the cornea in some cases. Any severe trabecular meshwork dysfunction can affect the prostaglandin and uveoscleral outflow. And the patient can be non-adherent and poor installation technique can be there. And measurement errors, the tonometer which we are using, the CCT can have effect. And disease biology like NTG, normal tension glaucoma and vascular factors, these all can affect the why medications fail. So here top 3 are considered to be true non-responders and bottom 2 the apparent. So in true non-responder, there is no pharmacological effect. It can be NTG vascular component, receptor issues and severe TM dysfunction. And there is something called a masked non-responder. Here there can be additional steroid which the patient is using, some Ayurvedic preparations, some other local medicines or some skin ointments or inhalers, which we do not ask always. And that can be a result of raised IOP. And there can be an angle closure component. It's always not that in a slit lamp you don't see a shallow AC, doesn't mean that there is an open angle. Always do a gonioscopy for all the patient. And he can be on some other systemic medication like beta blockers if he's using oral. The beta blocker topical may not affect. And IOP fluctuation is one important thing which we always miss. There can be a diurnal fluctuation which we may not see and that can be a reason for not response. And apparent non-responder is because of the patient issue, techniques, timing, missed doses and the measurement errors. So we have a drug check timeline that prostaglandin takes at least 4 to 6 weeks for its peak effect. Beta blockers 2 to 4, alpha agonists 2 to 3 and carbonic anhydrase inhibitors 1 to 2 weeks. So generally when patient come to you, first thing you do diagnose, stage the disease with fundus photo visual fields OCT and then you have to find the baseline IOP, see the fluctuations, diurnal curve and form a baseline IOP, then fix a target IOP based on the staging. It can be percentage drop or it can be according to the mild, moderate, severe disease. Then you call back the patient after starting him on treatment after 2 to 3 weeks according to the medication used. And if the target IOP is achieved, you just continue the AGM. But what to do if you do not have, it is not achieved? So it can be, when it is not achieved, it can be partial lowering or it can be total, complete non-response. Partial lowering is something you can have at least 20% of drop, but it has not reached the target IOP. And if still we have time for the drug maximum action, nothing wrong in waiting if the patient is not an advanced case. And if there is no change, you ask the patient how you apply the drop. If the patient is applying the drop and if he's an elderly, definitely there is chance that the technique is wrong or the drop is missed. The second thing, you look for a detailed history of any steroid. Third, you check the IOP reduction. The most common cause of non-compliance is difficulty in installation, forgetfulness, difficult schedule, cost and mistrust in the doctor. So these are all practical things which we see. We feel that the patients are using the drug, but generally in our population at least 50% of the people are non-adherent and non-compliant. So check if the baseline IOP is correct. Is the patient using it properly? Is the drug given enough time? Is there something masking the receptor? Is the percentage drop less than 15 to 20%, and is the nerve still progressing? You see all this and you know that it's a true non-responder. Then you can change the drops. So generally you ask the patient how you instill the drop. Look for any signs of, like if there is a hyperemia, we know that the patient has used it. Any side effects of the drug you can see. Ask for the bottle, like you have prescribed, how many bottles you have used, or you look at the bottle level, how much has come down. Ask the exact timing of the last dose. They would have missed last like previous night or morning. And when there is no partial lowering, you can always either change or add the drops. So generally in partial lowering, what we do is, we know that that particular drop is acting, so generally we add another class of medication. Or if it's a generic one, you can change even to the branded ones. And if nothing's working, you can go for SLT, trabeculectomy or KDB. SLT is a very good option. Even it works best in virgin eyes. But even with single medication, if you want to stop that medication, SLT really works in open-angle glaucomas. And if there is no change, you have to change. It can be class switching within the prostaglandin, or you can change to a different class, or you go with the mixed procedure or SLT, and if required, you can do the trabeculectomy. So this cycle continues till you get a maximum tolerable medical therapy. And one thing which I wanted to tell is, as madam said, rightly said, now we have the triple drug combination. We see lots of patients coming with triple drug combination which have started for the first time. We never know whether each drop is acting or not. It doesn't mean that all prostaglandins will act in all the eyes. Beta blockers, same with that. So you have to make sure that each drop is acting. Only then you ask them to continue it for the lifetime. So before starting the combination therapy, you can always call them back. If they are not high risk of glaucoma, any further loss, you can call them back early. Even if it is above 30, 35, you put them on an oral astazolamide, then put one single medication, call them back early. If you know it's acting, you can add another drop, and later on you can change it to a fixed drug combination. Make sure all the individual drops are effective. So vision loss is irreversible, but non-responders doesn't have to be. We need to be a little more patient in taking proper history and examination of the patient. Thank you.
Thank you, Dr.